So now that we've talked about ways to anticipate and manage patient behaviors and some alternatives to restraints, we want to really think about, when is it that point in time where we have to make that decision that a restraint is necessary? Sometimes we can do all the right things, try to de-escalate, try alternative interventions, and still that patient either continues with to display maladaptive escalating behaviors, or they're increasingly agitated, can't be redirected, and really pose a safety risk to themselves or others. In the behavioral sense, this would be threats to staff or self, exhibiting dangerous behavior, self-mutilation, threats like that. Or, for a patient who might be confused, it's just, maybe repeatedly getting out of bed and they're a fall risk. And, every intervention that you've tried doesn't seem to be working. That patient is still continuing to put themselves at risk for injury. So it's really that point where the patient meets this criteria that we've just discussed, and we really can't ensure the immediate physical safety of that patient or others around them, staff, family, etc. So that's really that point when we have to make that decision to apply restraints. So the first thing we need to really think about when we are considering restraint use is, what type of device we want to use. And when it comes down to considering devices, we really need to think about the concept of intent. We may have the same device, and depending on how we are using it, it may or may not be considered a restraint. And it's important that we understand if it is truly being considered a restraint in the regulatory sense, because then we have to follow the process of obtaining an order, ensuring that we're meeting all the documentation and assessment criteria, and all of that. So that distinguishing that, is it a restraint or not is a very important step. So, we have to think about, is this device being used to intentionally restrict a patient's freedom of movement? So as I think a pretty easy example here, we have a lap belt, and during our demo we, we'll look at the lap belt used in both different ways. But if this is secured to a wheelchair and fastened in the front, maybe it's for a stroke patient who has, left-sided weakness and is kind of leaning over, and we want to use that lap belt to just kind of help them sit up straight. We put the fastener in the front, and the patient is able to remove that. They have the motor skills and the dexterity in their fingers to unfasten that belt. That would not be considered a restraint. However, that same lap belt, if we secure that to the chair and fasten it in the back where the patient can't reach or remove it, then that would be considered a restraint. So it really, depends on how it's being used and the intent. What are we trying to accomplish with the restraint? Does that make sense to everybody? Oh, great. So one thing that's come up recently in a lot of conversations, and the Joint Commission has actually published some clarification statements on this, are the use of 4 side rails as a restraint. So this one gets a little tricky, I think. So essentially, we always kind of had heard in the past, I remember when I came through nursing school and was a new nurse, that never put 4 side rails up because it's considered a restraint. And that, is true in a sense. We have to kind of look at it again, is, what are we trying to do by putting that fourth side rail up? Are we trying to prevent the patient from getting out of bed, or are we trying to prevent them from falling out of bed? So if we're trying to prevent them from getting out of bed, then in this case, yes, the 4th side rail would be considered a restraint. If they are a person that's alert oriented, no cognitive or physical impairments that would prevent them from being able to safely exit the bed with that 4th side rail up, then it would not be considered a restraint. So that is a little bit tricky. It's really, there really aren't, I don't think, isn't really a need for that 4th side rail. Most patients, if they aren't at risk, don't have any confusion, don't have any, they're not a fall risk, they don't have any, they're not sundowners, cognitive, disabilities or anything like that, then, the 2 or 3 side rails is usually plenty, and they're really not going to be at risk for falling out of bed. So really, what I suggest to people is, if you're trying to figure out, okay, is this 4th side rail going to be considered restraint? Ask yourself 2 questions. First one, is my patient confused? If they are confused and you're putting up that 4th side rail, chances are it would be considered a restraint. And we have to think about it in terms of safety. That 4th side rail, and it was kind of articulated on the previous slide, really presents a greater injury to that patient who is confused, because they may see it as a barrier to climb over. They may get trapped between the top and the lower side rail. And if they were able to get over it and they fell, they're really now falling from a greater height than they would have if they had just fallen from the mattress level height. So that's why the Joint Commission has really, put a lot of emphasis on this, on side rails as a restraint. So the other question I would ask is, if I didn't have that 4th side rail up, would I be considering another form of restraint to protect my patient? And if the answer is yes to, either one of those questions, and, chances are it would be considered a restraint and you need to get an order for it. And truly, that's really not the best option to utilize as a restraint anyway, for the reasons we just discussed. So some situations when 4 side rails isn't considered a restraint would be if the patient's sedated, recovering from anesthesia, if they're on a stretcher because they're much narrower, or they're experiencing involuntary movements such as seizures and putting on the seizure pads for seizure precautions. So really those are your only exceptions. And sometimes families will ask to put that 4th side rail up, and we still need to follow the criteria that we've just discussed, and this is really an opportunity to educate the patient and the family as to the risks that 4 side rails present. And I think if that education is provided, then our families would have a good understanding and feel comfortable with leaving those at least one of those lower side rails down. So does that make sense to everyone? Anyone have any questions on intent and 4 side rails? And great. So we're going to talk a little bit about different types of restraints. Again, we want to use the least restrictive type, and the type of restraint needs to be based on the patient's behavior and condition. Really needs to correlate with the purpose. So some different types, and we're going to look at them in a little bit, are limb restraints. These are really good for patients who are agitated and are trying to pull at medical devices. Maybe they're intubated, or they have a central line, or a tube or something, and they're confused. Again, can't be redirected, and they this medical treatment, these lines or tubes are necessary for their care. Typically, we would use the soft limbs. In this case, the 4-point locking limbs would be, more reserved for your violent patients, and we'll talk a little bit more about that with the full body net. We have chest vests and lap belts. Those are good for patients who are confused and impulsive and are trying to get out of bed. Enclosure beds. Those are really good for your head injury patients. They give them a little bit more freedom of movement within the bed. But, you'd want to use those with a patient who, may become agitated if you used a more traditional device such as a vest or a belt. As I just mentioned, a full body net. We use these in conjunction with the 4-point locking restraints. These are really reserved for our, violent behavioral health patients. You always want to make sure the patient is in the face-up position when you're using a full body net. You never want to, restrain them face down. And patients in a full body net do need, one-to-one, continuous monitoring. That's really important. Any questions so far? Great. So here we just have a list, and these are all outlined in the restraint policy of the devices that we use here at Eastern Maine Medical Center. And then they're ordered from least to most restrictive. So our least restrictive restraints Some of these are actually not considered restraints, activity apron, mitts, foam cushion, things like that. Again, we still need to consider intent. We have our less restrictive, which would be your, freedom splint, your posy, then, posy net bed, your roll belt. I have a picture of the roll belt right here. Actually gives quite a bit of freedom of movement in the bed. We get a little bit more restrictive with your roll jacket, pictured here. And then your most restrictive would be your, limb restraints, non-locking and locking, and then your neck restraint, which is pictured here. Again, we don't like to use those unless we absolutely have to. So I alluded to it at the beginning of the presentation, but we need to think about different patients, different patient populations when we're considering restraints. We need to think about, I had mentioned, history of abuse, other psychological conditions. We need to think about physical impairment and limitations, and even communication, modes of communication and methods. For example, maybe a patient who is deaf, and making sure we don't restrain their hands. So we need to think about all these things when we're choosing a restraint. So, they may not necessarily be contraindications to restraints completely, but they're things that we need to think about would be patients with sleep apnea, hernia, seizure disorders, broken extremities, other physical disabilities or mobility issues, and just your elderly and frail patients. Again, psychological conditions, we talked about history of abuse, that really restraining a patient with that type of history can really be a trigger and exacerbate a lot of those emotions that were associated with the abuse, and bring on some behaviors that may kind of escalate the situation even further. And then claustrophobia is also another consideration, so a lot to think about there. So once you've determined, that the patient needs to be restrained, and generally when we go to obtain an order, we have a sense of what type of restraint would be appropriate for that patient. We need to get an order from the physician. So, a restraint order, just a few things here, can never be a PRN. We have to get a specific order for that instance. And if a patient, if we say we get an order for, a roll vest, and then that we find that that's not restrictive enough, and the patient's still able to get up and get out of bed and falls, and we need to get a more restrictive device, then we actually need to get a new order for that patient. So we have some different order frequencies that are required with your behavioral patients. The nurse actually needs to renew the order, and I say kind of order loosely because it's different than the physician order. That needs to be renewed every 4, 2, or 1 hours, depending on the age of the patient, as indicated here on the PowerPoint. And then the attending physician, needs to assess the patient and write a new restraint order every 24 hours. So it's kind of a twofold process there. For medical surgical patients, that order needs to be rewritten every calendar day. So just a few things to remember when applying a restraint. Only staff who have documented training and competency, such as this course this class that you're taking today, can apply restraints and monitor patients in restraints as well. We need to make sure the restraints are applied in a manner that respects the patient's dignity. So the patient needs to be clothed. We need to be careful that we're not violating the patient's, physically, and maintaining their privacy at all times. Because this can, obviously can be very traumatic for patients. Any restraints that require tethering, such as, limb restraint, need to be tied with quick release knots, and that's for safety. And these knots can never be tied to movable parts of the bed, such as rails or hinges.